problem. Let's get started about this idea of next steps with ibrutinib and CLL, and I just thought I'd use this case as a jumping off point. It's not really necessarily that we go through the case, but I think it does help us figure out as a jumping off how to think about all these issues that I'll try and address. So this is a 61-year-old patient, has a 17p deletion. Dr. Eradat really put that well. Patients with 17p deletions don't do great with chemoimmunotherapy, and so ibrutinib is typically what we do. This was a recent diagnosis. Patient had some fatigue, adenopathy, good bulky disease, 10 centimeters, a big spleen as well. White count was a little bit high. Remember, white count by itself in CLL does not cause symptoms, so a high white count is not by itself a reason to be treated. But this patient obviously has other things, including the fact that he has some thrombocytopenia. And so what do you treat with? I think in this day and age, in frontline treatment for 17p, the answer is ibrutinib. In indolent lymphomas, CLL, it's very rare for us to say that there's a right or wrong answer, but in this case, I would say outside of a clinical trial, upfront first-line therapy for 17p deletion, for me at least, the answer is ibrutinib. But that's not always great for everybody because some people might not tolerate that drug, and we have to think about what we do for that patient. And we have to also think about what we do once the drug stops being active. What do we do next? And what are these other effective agents, or are they even effective after failing ibrutinib for one reason or another? And actually, maybe we can keep people from relapsing, right? Maybe we should be thinking about maintenance strategies with new drugs in CLL, not something that we've largely done. But what I want to do now is kind of address some of these key questions as we move forward, and that's already been done there. But some of these questions to think about are, should ibrutinib actually then replace chemotherapy in the frontline setting for all patients with CLL, not just those for 17p deletions? So I will try and give you a little bit of update of that data. You saw a little bit of that from Herbert, but something we'll focus on a little bit more. And really, if we're going to treat people with these agents, we always tell them, geez, you're going to be on these pills for, and people love to say this, the rest of your life. Of course, that's not true. There will be a time when they will come off of the drug. But what if they are on the drug for a long period of time? What are the long-term risks and benefits of doing that? It's largely been unknown. And again, what do we do once people have intolerance or have to stop in that regard taking the drug? So let's focus on the frontline therapy. You already know this. The RESONATE-2 trial was the trial that led to the approval of ibrutinib in the frontline setting. This was updated by Paul Barr at ASH last December. Just remember, this was a flawed study from the start, you could say, perhaps, because it compared ibrutinib to single-agent chlorambucil. I hope this is the last time we ever have a single-agent chlorambucil trial that's done. But the ibrutinib part of it was important, and I'll show you that. These are the patients. They were patients in the mid or early 70s. You can see if some patients were quite elderly, 89, 90-year-old patients on the trial. I think that's really important when you remember we're not going to give those patients FCR or commonly not even dose-reduced bendamustine and rituximab. And a variety of other factors there, including some poor renal function, as well as some anemia, thrombocytopenia, and high-risk disease with 11q deletions. There were no 17p deletion patients in this trial because ibrutinib was already approved for 17p deletion patients in the frontline setting at the time we did this. And this was what the trial showed. You already saw this curve. Again, want to say that it's not surprising that the ibrutinib arm, which is the top arm, is so much better than the chlorambucil arm, an 85% or so reduction in the risk of relapse, progression, or death. We expected that. That's a straw man, easy to beat. But what I think is impressive is how those patients did on the ibrutinib arm for a considerable amount of time. Now we have, with this update, a median follow-up of about 2.5 years. Not a long time, but actually suggesting that people are alive and for the most part well, at least from a standpoint of not relapsing, with now about 90% of patients at 2 years still again on the drug and doing well. And that also led to a survival advantage, and that's shown here. That's very important to say that most patients who get this in the frontline setting are going to do very well. And we've also learned that with this update that responses improve over time. So when we first reported this in the New England Journal, we noted that there was about a 6 or 7% complete remission rate. Now with longer follow-up, with more people on the drug for longer periods of time, now we're getting complete remissions of around 18 to 20% or so. So CR rates go up over time when you're on this agent. That's very important. And that's irrespective of the high-risk features, at least in this study 11Q, or being unmutated IGHV. And this is probably the most important part of that slide, I think, and that is that you can see in the middle of the slide that almost 80% of patients, 107 of the 135 patients at this median follow-up of about 2.5 years, were remaining on the ibrutinib. And if you look there under the treatment duration, you can see that 83% of patients were on the drug for over 2 years. Why did they come off of the drug? Not surprisingly, there are people that come off the drug for adverse events. That's the most common thing that we see in the frontline setting. So you see 12% of the patients coming off of the drug for adverse events, but very few patients relapsing or progressing in the frontline setting. So this is suggesting that maybe people will continue to do very well, but how long will they do well and how well will they tolerate it? Well, this was also updated at ASH. Susan O'Brien presented this data from the original 1102 study that we did, where we actually took a variety of patients, both treatment naive and relapse refractory, who got once daily oral ibrutinib. There were a couple of different doses, but the majority of patients received the standard 420 milligrams a day. Again, these are patients in their around 70 at a median age. Small number of treatment naive patients, only 31. But the important point of this slide and these patients is that this is the longest follow-up we have of any patients who have been on ibrutinib. The longest patient now on ibrutinib is about a little over 6 years out on the drug. This is 5-year follow-up data of these patients now. 5 years follow-up data. Again, you can see some of the features of these patients shown on this slide. Some of them had bad cytogenetic risks. Some of them had unmutated IGHVs. Mostly all of the higher risk features, as you would expect, are in the relapse refractory setting. And I think the other thing that was important is that when we had this original first trial, that the people in the relapse refractory setting were patients who were in fairly significant need of a novel, different therapy. The median number of prior therapies was 4. In fact, almost 60% of the patients had more than 4 prior therapies. And when we look at now the long-term follow-up, this is again 5-year follow-up. If you look at how long people are on the drug, turns out 65% of the patients in the treatment-naive group are remaining on the drug for 5 years. And 30% of these high-risk patients who had 4 or more prior therapies at a median remain on the drug for 5 years. So why do you come off of the drug if you're on it for a long, long time? It turns out it's not surprising. If you're in the treatment naive cohort, you might have come off because of some adverse event, maybe about 1 in 5 or 19% you can see there. Sorry, I can't really use the pointer because of the 2 slides, but hopefully you're following me. And then in the relapse refractory, you can see that the biggest problem is, of course, disease progression. And we'll focus in a little bit on what do you do once you progress on ibrutinib. And again, the longer you're on the drug, the better chance you have for a deeper remission or a better response. So of course, this takes into account people that fall off over time, but with 5-year follow-up, the CR rate's now around 30% in the frontline setting, and about, again, maybe 10 to 15% or so in high-risk, multiply pretreated patients in the relapse refractory setting. These are the survival curves. Dr. Erdath showed you these briefly. Not surprising, people in the treatment naive group have done very well with now 92% of patients who are alive and progression free at 5 years in the treatment naive group. And in that heavily pretreated relapse refractory group, almost 50% of them are alive and progression free at 5 years. And that translated to the survival curves that were quite encouraging. Again, 92% of patients alive in the treatment naive at 5 years. Remember, This is a disease of older patients. Again, some of these patients were in their late 70s or older. So that those deaths take into account deaths from anything, not just from CLL. Remember that. I think that's all extremely encouraging. And also what it means is that people are able to tolerate this therapy for, well, probably a long time, at least with this 5-year follow-up. These are showing you the reasons people come off of the drug, and it kind of tries to break it out of where this happens. And I won't go through this exhaustively, except to say that first you can see that most people don't come off of the drug for an adverse event. And when they do, they usually happen early as opposed to later. Most adverse events that cause discontinuation with ibrutinib happen within the first year. If you get out over a year, you're not usually seeing those. So the cumulative events go down over time, taking into account the people, of course, that come off of the drug as well. So every single adverse event that we saw in this trial actually went down over time except one, which was hypertension. Hypertension might have actually been showing us a little more activity or relevance in later years. But remember the 3 major side effects of ibrutinib. They're hypertension, atrial fibrillation, and major bleeding. They were not cumulative, and hypertension might be the only one that we see more relevant or more prevalent, I should say, at later years as opposed to early years. And the other thing that's very important to note that we saw in this trial is that infections and infectious risk went down over time. Most of the infections happened within the first 6 months, and immunoglobulin levels were shown to improve over time while maintaining on this drug. Now, how this looks after 5 years or more, we'll see, but it seems to be quite encouraging. But people do have to come off of this drug. We have all seen that. It can be a problem. What do you do if you're no longer tolerant to ibrutinib? This slide is just from the Ohio State group, and for some reason I lost the reference there, but you can see that the top curve there it says other event. That means adverse events. You can see that they happen earlier with progression being later. And, about a third of patients, at least in the relapse refractory patient population, have been shown to need to come off of the drug for an adverse event. So what do you do? Well, it depends on what the problem is. Do you need anticoagulation because of something like atrial fibrillation or something? Well, I think idelalisib and rituximab is a reasonable option. There's a lot of caveats with that, and I think some of the newer agents would probably replace that line on this slide for me if I do that again in another year, or do this talk again in another year or so. What if they have infections? If they're early, it's really unlikely to be due to the therapy. We know that CLL has an underlying immune dysregulation, and people do get infections, older people. And as I said, usually the immune function improves over time, and that's very important to understand. But there are other intolerant symptoms that people can see. We see a lot of arthralgias, we can see myalgias, rash can sometimes be significant with mucositis or mouth sores as an example. All of those might suggest to us that we need to do something different. I think idelalisib and rituximab is reasonable. I'll show you some data, I think, in the next presentation about what that might look like if you switch from ibrutinib to idelalisib. Or maybe we actually just go to a newer, better ibrutinib. Maybe we go to the next generation ibrutinib or an alternative BTK inhibitor. Remember, ibrutinib is a Bruton's tyrosine kinase inhibitor. And that's leading us to now a discussion of acalabrutinib, which I suspect you might have heard of. We published this in New England Journal in early January, or about a year ago. And this was a study looking at relapse refractory patients. This was the 001 trial. And the difference between acalabrutinib and ibrutinib is that it's thought to be perhaps a more selective tyrosine kinase inhibitor. So it does also obviously target BTK, but you can see there that it has less interaction or affinity by IC50s for TEC kinase or ITKs. And that's perhaps why this drug might have a better side effect profile. And in fact, if you look at our first 60 patients, you can see that the adverse event profile was very, very tolerable. Actually, we didn't see any atrial fibrillation, we didn't see any major bleeding, and hypertension is not thought to be a major problem, at least on this early data. You can see, of course, that the response rates in these patients, these are not ibrutinib failures. I want to, for the large part, I want to point out, these are people who have a response, so the drug's very active. 95% of patients have a response, even those with 17p deletions. Not a large number of them in this trial, but I think very important to note as well. And just like ibrutinib, you can get a very quick reduction in lymph node mass. That's the solid white curve. Comes down as the sum of the product diameter. I'm not sure why the colors got messed up, but you get the idea. And I don't understand why this always kind of happens, right? Anyway, the bottom dash curve suggests that the white count will go up and come down over time. Remember, you're mobilizing these cells from their microenvironment, the bone marrow, the lymph nodes. They come out and circulate in the blood. The white count will elevate with any BTK inhibitor. Also with idelalisib, don't be alarmed. That does not mean that the drug is not working. So this drug is a very exciting active drug. This is the obligatory waterfall plot. You can see excellent reductions in adenopathy. I could show you something similar for absolute lymphocyte count. And at this early follow-up, it does appear to be encouraging, again, relatively small numbers from progression-free survival. But the issue that I was trying to get at is not that entire study of using acalabrutinib, but what about the ones in that study who actually were intolerant to ibrutinib and then went on to get acalabrutinib? There were 33 patients in this trial who had to come off of ibrutinib because of a toxicity and went on to get acalabrutinib. And these are the patients here. I'm not going to belabor those 33 patients. They're CLL patients, as you would expect. They failed ibrutinib not because of progression, but because of intolerance. And you can see that most people actually did very well. The response rate was about 80% for patients going from ibrutinib to acalabrutinib. Very few patients with progressive disease, 3 out of 33. By the way, the median follow-up is still relatively short, about a year. But you can see most people were doing fine staying on the drug. And these are how they did. As I said, the response rates were excellent. Overall response rate was about 80%, switching from ibrutinib to acalabrutinib. That's all good. But really the reason you switched is because somebody had a symptom or a problem with the drug. So it turns out that none of the 33 patients had an exacerbation of their symptom that caused them to move away from the ibrutinib. And there were no one who had a worsening of their symptoms, and there were actually only 2 patients who had recurrence of their ibrutinib intolerance symptom. Only 2 of the 33. And even when they recurred, they were not as bad from a grading standpoint as they had been on the ibrutinib. So very, very well tolerated. Even though a third of patients got some adverse event recurrence, usually that didn't cause any problems. So what do? I think these targeted agents, in particular ibrutinib, is a paradigm shift. As much as I've argued again for continuing chemoimmunotherapy, we know the long-term results show very durable responses and very tolerable side effects. And we do know that CRs go up over time, but they're still limited. Again, the best we've seen is maybe 30%. We have a lot of work to do there, and so how do we do that? A variety of other agents, maybe better targeted therapies. I think immunotherapies, and I think John's going to talk about that later, at least with regard to lymphomas, are an incredibly exciting burgeoning area of exploration, including CAR T-cell therapies. So that's my first 20 minutes. And